Okay, let's get started. Well, good evening, everyone. Thanks for attending WPMN's talk today on F1 medical emergencies. This talk will hopefully leave you feeling better prepared to go into your new roles, as we aim to give you a refresh on the management of common medical emergencies that you're likely to come across as an FY1. We have the pleasure of being joined today by Dr. Cleona Lewis. Cleo is a post-foundation years doctor currently based between Northampton and Bristol. She works across a variety of specialties, mainly emergency medicine, acute and general medicine, and pediatrics, and so is well versed in the topics. This summer, she will also be moving to London to work in St George's Emergency Department, and so is the perfect speaker to be giving this talk. Before we begin, I would just like to ask everyone who attends to please fill out the feedback form, which will be posted in the chat towards the end. There will also be an option to enter your email so we can send certificates of attendance to all of those who do. Without further ado, Dr. Cleona Lewis, everyone.
Hi everyone. This is my first ever Zoom talk, so it's very strange, everyone being quiet. It's very nice. I'm Cleo. Thanks for introducing me. Thank you all for coming this evening. First things first, congratulations. I'm assuming most of you have just started F1 today, basically. That's a huge achievement and it's where you wanted to be, so that's cracking. Anyway, yeah, as I said, I am like an F3 doctor, basically. I'm starting ED next week, and I'm also 25% clinical teaching fellow with St George's. So yeah, that's me. Anyway, obviously the talk is called Medical Emergencies in F1. I want to just emphasise it's, number one, it's common emergencies, and number two, it's not vision, it's revision. So I'm not teaching you it because actually you already know it, and you probably know it better than I do conceptually because you've just done your finals, you all have passed them, so you know stuff. This is really about doing a whistle-stop tour of the really important things and getting your brains thinking like the F1 on call, which is what you all are now or will be very, very soon. So yeah, non-exhaustive, not everything, not perfect. That is the takeaway point of this slide. Safety basics, obviously it's a great brand, but also I want to start with the basics. So I'm not going to launch straight into your topics, as in all of the different medical problems. I want to just talk a little bit about the basics of being a good F1 on call and being able to deal with emergencies and deal with stressful situations, and how I like to approach things, and so you've got a nice standardized, structured way when you're on call. So first up, kit list. Whenever you go camping, go on holiday, you know, go into war, it's always good to have a list of the kit that you need, because then you feel organized and you feel in control, and also you're not underprepared. So the kit that I put down, have a routine. Obviously that is not a bit of kit, but I think both with your day jobs and your kind of day-to-day life as a doctor, and also with your on calls, having little routines, and that's tiny things, whether it's always having a coffee before your shift, always brushing your teeth. I hope you do that anyway. But then particularly on call, I have nice little routines that like switch my mind from being an F1 sat in the mess waiting for my bleeps to being a doctor who's got to deal with a sick patient. So personally, when I'm kind of walking to see a sick patient, I'll always re-tie up my hair, and it just kind of focuses my mind. It's a little bit like Johnny Wilkinson, if you're a rugby fan. Before he takes penalty kicks at the goal, he always does this funny squat hand hold thing. So it's just like that, and it basically focuses your mind. Obviously, you need a pen and paper. Have your handover list printed so that you can annotate it if stuff changes with patients and with jobs. Obviously, you need your stethoscope, your pen torch, stamps. They're the little stamps you might have got given them today, just with your name, your GNC number, save a bit of time. The apps. I put a slide at the very end of this presentation. You may well be aware of all of the apps, you may not be, but there's a lot of apps that you can have on your phone that are amazing sources of knowledge, sources of drugs, so BNF for prescribing, and sources of your bleep. Where are you going to have your break? Because you want it near enough you know what food you've got, have some banging food, and sort of pace your shift, and just know that, oh, actually, do you know what, it's 4 hours in now, or it's 5-6 hours in, I should, you know, even if it's 5 minutes, take a break. Know who is on your team. By that I don't mean know their shoe size and where they're going on holiday. I mean know who is your SHO, who is your med reg, who's the consultant, if that's relevant, and know how to get to them. So one, you want to know their bleeps. That will be a standardized bleep for the hospital. The bed reg will always be on whatever number, but ideally get the numbers, because WhatsApp's a great tool, or WhatsApp or text, just to say, oh, hey, it's not medically urgent, but oh, there's an ECG, I'm just not too sure about it, want to have a quick look at it. So yeah, have a little network for contacting them. And then also know how to access trust guidelines, guarantee that will have been hammered home to you throughout medical school and induction. Yeah, just make sure that you know how to get there quickly, so you're not stressing about that. Okay, next thing is getting the call, getting the bleep, and that's sort of like your first panic moment. I mean, you might be panicked before, but your first real moment where you're like, oh crap, this is real. I put S bar in the middle, I put a line through it, and that's not because it's bad, it's great. I just think it's a bit over technicalized, and that's not a word, but it's over technicalized for when you're actually a little bit panicked. Also, when you're getting called, it should be them doing the S bar, but actually, when you're listening, I like to have a slightly more simplified structure in my mind, and that is who, what, why, when. So who, what, why, when, and breaking that down, number one is the who. So if I'm being called about a patient, unless it's ridiculously urgent, like anaphylaxis, I want to know who they are. I want to know the name, their age, the gender, and then ideally a patient identifier. So whether that's hospital number or date of birth or whatever, but something I can scribble down. So if I need to look up stuff on the computer or whatever, I need to hand them over, I've got that. So that's your who. What? Number one, what is the problem that you are being called about right now? It's important to get that out in the open early doors so you can prioritize it, because you might be doing something else kind of important whilst you're getting this call. And early doors, if you know that this is just someone that needs some paracetamol re-prescribing, you can sort of like mentally bin that. Like you can listen to the end of the call, but you just chill a bit. You want to know what treatment they're already on, because it might be that they're already being treated for a heart attack and they're having some more chest pain, and it's kind of relevant if they're already on treatment for it. And number three, is there an escalation plan? And by that, I mean, are they for resus? Are they for compressions? Are they for ITU? Or are they for ward-based care? Because if the nurse is called and actually that's their escalation of treatment, you're going to approach that a bit differently to a young patient who is for everything and they've suddenly become really sick. So that's always good to know, just in the back of your mind. But again, if you drop it, like don't worry about it. It takes a little bit of time to perfect this process, but those are the sort of what questions I want to know about. Then the why. Why are they in this hospital? Because the problem that you get called about might not be the reason that they come into hospital. They might have come into hospital with a raging pneumonia and now they're having a stroke. It's good to know why they're actually in hospital. And you want to know why you've been called. And I know that sort of ties in with what is the problem, but why are you being called? Like, what is it that that nurse actually wants from you? Because you might have a really experienced nurse who sort of like knows the answer already, but why do they want you? Is it because they want you to do the prescribing? Because they want you to escalate something to someone else? So yeah, sort of tease that out. It doesn't need to be an overt question because it could sound a bit confrontational. But just establish why is it that they're calling you, and then when is quite important. When do you need to get there? Is it like right now, drop everything? Is it at some point this evening? Or is it like, oh, do you know what? You don't need to come over, but this is a job that you'll need to hand over to the night team or whatever. And likewise with when does something need to happen? Does a blood need to be taken at this time, etc. Cool. So that's your who, your what, your why, your when. As I said, it's just a simplified way of assimilating information in your mind, because that can often be the triggering stressful bit, is getting that call and bearing in mind that the person calling you might be stressed as well. It's just sort of like little things to just write, how can I tease this from the conversation? You might not be able to direct that conversation. It might just be word dump. If you can have those things in your mind, that's good. Also, I appreciate that these slides are kind of wordy. I think this is definitely going on YouTube and you'll almost certainly get the slides, so don't worry about writing stuff down. Should have said that beginning. Oh well. Cool. So moving on to arriving at your very first on-call patient, take a minute to appreciate these pictures, because that is how I felt I was called to a patient with chest pain. Ultimately, they were very well. It was no biggie. But when I got there, no matter how many times I told myself in my head that I knew how to deal with chest pain, I knew what the causes were, I knew what I'd do, I still had this feeling, it was only fleeting, but I walked in and I was like, oh my God, I feel like the GC. I feel like I'm going to poo myself, and I really would just rather be anywhere but here. That's normal. That's very normal, but that's something you need to feel for 2-3 seconds. And then you want to go back to a system and back to that kind of methodical, simple way of approaching things that you have practiced again and again and again and again in medical school, and you've almost got bored of. Okay, so have your GC moment and then be like, okay, right, let's start at the beginning. Okay, so these are sort of the 5 things I would say that you need to do. And the first one I think is the most important is look at the patient. I only started doing this at the end of F1. I almost over complicated things. But actually, even if it's a glance, if you look at that patient and they're sat up and they're reading Hello magazine, or they're on the phone, or they're eating, you can breathe, you have time. So always look at that patient. It will just give you information. If they look like absolute shite, all you need to do is call 2222 and either put out a rapid review or a medical emergency or a crash bleep, because you think actually they're not arrested right now, but I think they're going to be there very, very soon. So always look at them first, give you ideas. Then number 2, A to E. I don't need to go into what that is, but my God, it's a godsend, because it just really keeps you on that straight and narrow. It is so tempting to panic. Don't. Just airway, breathing, circulation, disability, exposure. You will find the answer by doing that. Then if you need to do immediate treatment, whether that's start albuterol nebulizer, give them adrenaline, whatever, do it then. Then you want to have a really quick read of the notes. If you're in a fancy hospital, you might have already done that, because I've got an app on my phone called CareFlow that has all the patient notes. And whilst I'm walking there, I'll read about my patient and I'll know why they're in hospital, what we're doing for them, etc. But you might not do that. So just have a quick skim read of the latest ward round and maybe their clerk and admission sheet. Then you just know a little bit about them. And also knowing the plan from that day is great, because if the planner said, oh, this patient might spike a raging fever and get hypotensive, and in this case do X, Y, Z, that's great to know. And then at this point, you can escalate if necessary. You might be like, oh, they're not dying, but they're a little bit complex and we might need to do complex things. Or I just feel uncomfortable. You can either call your SHO, you can call the MedReg, or you can put out a rapid review, whatever you see fit. Early days, it is literally whatever you feel like doing. There is nothing else to it. If you don't feel comfortable, you don't feel safe, you escalate to whatever level you want, and that is fine. And even if people answer the phone and are mildly grumpy, that's only because they're having a shit day and it's not because you've done anything wrong. Cool. And then the next step is sort of obvious, but like your further actual treatment, organising any investigations, discussing with relatives if that needs to be done. Cool. So I think that's the basics hammered down. This is the half of the talk that's just gone that I would prefer you to take home stuff from. The next bit is just going through different presentations. But you've done med school. I think it's about having the basics in your mind. So spend time honing that, thinking through that. Okay, cool. So for everything that I'm going to go through, it's a whistle-stop tour. I'm not going to go into particular details. It's not perfect. It's not scientific. It's not exhaustive. But can we just assume that for everything that I'm going to tell you to do, you're always going to look, you're always going to do an A2E, you're always going to call for help if it's needed, and you always are going to look at the trust guidelines. So even if I've not written that on the slide, that's like non-negotiable. Okay, right. So first, we'll start with the art attack. NSTEMI obviously is a lot more common. I'm assuming you all know what that is. So you get called to query NSTEMI. First thing you're going to do is you're going to make sure you've got 12 lead ECG and that TROPs are going to get sent off, because that's how you confirm diagnosis. Oxygen, I've written 90 to 94%, because that's because in EM, in our EM textbook, that is what the guidelines are. You don't want to over oxygenate them, you get free radicals, blah, blah, blah. Anyway, let's not get bogged down in that. You want oxygen. You want GTN, see if it helps with the chest pain. It could be unstable angina, and also you're going to vasodilate the coronaries. Then you start with your dual antiplatelets, always aspirin, clopidogrel. Then you want your morphine and your antiemetic, because morphine is for the pain and also vasodilation as well. Antiemetic because morphine can make you sick, but this point, if you think they're having an NSTEMI, you want to chat with a senior, ideally the med reg, because even if it's an NSTEMI, they might need to go to the cath lab. So you just want to let them know. They might be like, yeah, that's fine, crack on. Don't worry about the cath lab, but just have that discussion. Then if it's an NSTEMI that's not going to the cath lab, you want to do anticoagulation. I put fondaparinone here, but pay attention to the bit in red. Every trust has different NSTEMI plan, different antiplatelets, different anticoagulants. Just follow that and you're golden. And consider a chest x-ray because they might be going into heart failure, they might have other causes of chest pain. And then consider a GTN effusion. I wouldn't be worrying about that, especially in your first job of F1. I think that would probably be an SH or a med reg decision, but it's just something to know that you can do with sort of like continuous nitrates. Cool beans. Right, so your STEMI, obviously a little bit more dramatic, probably a little bit more terrifying when you see those ST elevations on the ECG. Similar basics, the ultimate difference is that you want them to go to a cath lab. To get them to the cath lab, that cath lab needs to be activated. To do that, cardiology needs to be called, and either you're going to call the med reg and they'll activate it for you, or if you're in a hospital where it's in the daytime, you just call the cardiology consultant or reg on call, but just know what the sort of etiquette, but it doesn't really matter ultimately. If you call any one of them, stuff will happen. So yeah, you want your ECGs, oxygen, get the seniors involved, and then you can start with your morphine, your aspirin. Second, antiplatelets, basically as per guidelines. I'm not going to commit to that. Some guidelines might not even want it, but yeah, ideally at this point then they're like the wheels are turning and they're on the way to the cath lab and you don't need to think about them anymore. But if you're in the Highlands or Islands, you're very far away from a cath lab, you might start a GTN infusion and the med reg might totter along and decide to thrombolize them, but that's not your issue. That's way above any of our pay grades. Cool. PE is quite a nice and simple one. Mostly it's people with a tachycardia that's unexplained and a new oxygen requirement, a little bit of chest pain. Hypertension is a late sign. Hemoptysis you basically never see. There's other sort of like vague symptoms, but those are your main ones. Think about, are they at risk of it? Are they immobilized? Are they post-op? Are they a clotty person? Do they have a broken lower limb? Are they sepsis? Are they whatever the thing? Oh, COVID. That's a big one. Obviously at the moment that makes you very, very, very clotty. So think about those. Are you suspecting PE? If that's the case, if you suspect PE and there's no other contraindications to therapeutic dose collecting, you give the therapeutic dose collecting because then you're treating the PE and it's low risk and high reward, and then you need to make that definitive diagnosis. So that's always going to be either a CTPA or a VQ, depending on your hospital and the patient. Are they pregnant? Are they old? But the other thing is you always need your chest X-ray because that's just basically every radiological word. I think radiologist policy is a chest X-ray because it's an easy way of ruling out other causes of PE mimics, such as pneumonia. If they're unstable, and by that I mean hemodynamically, you need senior support because they could deteriorate and essentially arrest. They may be peri-arrest and they may need thrombolysis, but yeah, let your senior know. But also PEs, if they're small, they can be managed by an F1 quite easily, and so don't be worried about that. Pulmonary edema, you might be I would imagine you've done loads of sim on this, but essentially fluid on the lungs. So you want to get oxygen in and you want to make it easier for them to breathe. So you're going to sit them up. You want to listen. Can you hear crackles bilaterally? If you can get a chest X-ray, at the bedside, or if they're not too sick, send them down to chest X-ray, an ECG, just to make sure they've not got arrhythmia precipitating that heart failure, and just a really quick review of the history, whether they're in hospital, do they have heart issues, etc. It's most likely pulmonary edema is most likely going to be decompensated, left-sided or congestive heart failure, but there are other things that can cause it. Overwhelming sepsis, ARDS, low albumin, intracranial bleeds, or you've literally just flooded them with far too much water and they don't have the kidneys to cope with it. Treatment is, other than oxygen and sitting them up, it's diuretics, so furosemide or bumetanide, IV at first. If they're already on a diuretic, look what dose they're on, because actually if they're already on 80 milligrams of furosemide a day, your standard 40 milligram push is not going to cut the mustard. So just make sure you know what they're already on. Also review their IV fluids, because if they're on like a litre of fluid per hour, that's obviously a terrible idea. Obviously, you need to stop that within reason. And then you want to make sure that you kind of keep an eye on them and review their response to treatment, and escalate early, because they may need more diuresis, they may need infusions, they may even need CPAP. But yeah, it can be quite a satisfying one to manage, you know, if it's a simple one, because it's like relatively quick results and you're like, yeah, I did it, fix them. But also they can just not do well, and in that case you need help from friends. Asthma, not too much of that on the wards, more an ED thing, but it can still happen. Same principle, sit up, oxygen. Salbutamol as your treatment, so you back-to-back neb them. That's 5 milligrams of salbutamol. You can add in ipratropium bromide as a neb as well. That's 500 micrograms. Get an early ABG, because you want to know, are they tiring? You know, are they starting to become acidotic because they're retaining CO2 because they just can't breathe fast enough because they're exhausted. Then IV hydrocort and IV chlorphenamine, I hadn't written that in there. And then your next step up, if that isn't working, would be IV Magsolf. But at that point, you should definitely have escalated senior help. If you've got an SHO that is comfortable, they will give the Magsolf, but they will also probably let their med reg know. And then obviously, you know, there's more steps going on from there. But yeah, you know, you just basically want to open those airways with your salbutamol and ipratropium, and then you want to make sure they're not tiring. That's your goal. Type 2 respiratory failure, I'll just touch on. That's basically, you might see a lot of, it's people with COPD that rely on a hypoxic drive, so they require lower oxygen sats because they're used to being a little bit hypoxic. They go into hospital, they get given oxygen, their sats go up, they lose their hypoxic drive, so they're not breathing as fast, so they're holding on to CO2, and then they get CO2 narcosis, and they just drop the GCS, and that will be fatal if you don't reverse it. The treatment for that is BiPAP ultimately, and also taking off the oxygen and putting them to their target sats. If you're going to be starting BiPAP on someone, you definitely shouldn't be doing that as an F1. I mean, like, someone can walk you through it, but you definitely need to know your SHO, let your reg and SHO know about that. Anaphylaxis, again, an emergency, can happen on the ward, especially with drug errors. That's, you want double two, because they can go downhill real quick. To diagnose it, just be aware that, you know, a nurse might call you saying, oh, doctor, I've given this drug and now they've got a rash all over their legs and their tummy. That's not anaphylaxis. Anaphylaxis is 2 of the 3 of mucocutaneous, so lip and tongue swelling, hypotension, and respiratory compromise. I think it's actually usually pretty obvious if it's anaphylaxis. Some people will just go like, literally that, like they'll have their allergen and they'll be on the floor, gone. Other people, it'll be like 15 minutes later, the tongue swelling, they're feeling really dodgy. They will tell the nurse that they feel really dodgy because it is a like feeling of impending doom. Then your goal is your IM adrenaline, and like, that's not negotiable. You just shove it in. If in doubt, do it. Upper outer thigh. Don't worry about the dosing, because if it's coming from the crash trolley, it's going to be in a pre-filled syringe. But for an adult, it is 0.5 mils of 1 in 1,000 adrenaline, and that's 500 micrograms. Don't panic about the dose, as I said, just get it in them. Then remove the trigger. You know, if they've got a IV push of penicillin in, get it out of them. And then you give them the IV hydrocort, chlorphenamine, potentially salbutamol if they're a bit wheezy, and then let the seniors know, because they're going to want to be closely monitored, because they're then at risk of a biphasic reaction, which is 6 hours post initial anaphylaxis. They sort of, then their immune system has another little panic and gets stroppy, and they have another anaphylaxis, so they want to be monitored. Cool. So yeah, anaphylaxis and friends, adrenaline and friends. Seizure, that was something I just found, I just really didn't want to see a seizure. I don't know why. I think it's because I didn't like the doses of lorazepam or something stupid like that. Anyway, it is quite simple, because there isn't much you can do for it initially. It's just about putting some oxygen on them and sort of maintaining their airway. Like if it's a grand tonic seizure, it's difficult. If you can get an NPA or an OPA in, that's great, and put your oxygen on, but you know, it's difficult. Then you want to time it, because the real worry is A lot of seizures will self-terminate, especially if they're known epileptic. But if they get to 5 minutes, you need to start about intervening with drugs. The drugs, the main drugs, first line are benzos. So depends if they got a cannula or not. If not, you can do some PR diazepam or some buccal midazolam. They do have IV access, that's great. And you can give them lorazepam or you can give them diazepam. Then you want to monitor, and around 4 minutes time, consider giving a second dose of benzos. At this point, you will definitely ask for help. You definitely fast bleep the med reg, if not put out double two, because you're sort of drifting into the status epilepticus territory. I put here if they're alcohol withdrawal, because that's a common cause of seizures. We're pretty good at monitoring people withdrawing from alcohol, so we see less seizures. But if they are, you can give IV Pabrinex, which is thiamine. If the seizures are ongoing, obviously I've already said you get friends, but you get double two. They're going to need more treatment like phenytoin, and they'll probably need an RSI. But that's beyond your competence. What you want to do is oxygen, airway, time. Oh, also check BM. I didn't read that, but check the blood glucose, easy reversible course, and then benzos. Cool. Stroke is, I feel like it's kind of an easy one, but maybe that's just, I think like that, because there's not much you can actually do other than actually decide that this is stroke. That's quite important. And not decide that it's stroke, because actually the med reg is, but think this could be a stroke. So nurse calls you, are they fast positive? Have they got new neurology? Is there any risk factors? What they really need is a head scan, because you need to know, is this a bleed or is this an infarct? And at that point, once you've made the decision that this patient probably needs a CT head, then you just need to put out a thrombolysis call, because if that's a stroke, a new ischemic stroke in hospital, you've got the potential to get them thrombolized within an hour, and that would have massive positive outcome for that patient, because if they're out in the real world, they're probably not going to get thrombolized until 3-4 hours realistically, by the time they get conveyed to hospital, get assessed, etc. So yeah, if you decide that this is a patient you think is having stroke, you think they need CT head, you need to put out lysis call. Obviously, if it's an infarct, the treatment is aspirin plus minus thrombolysis. But again, that is way above your pay grade. It needs to be a med reg making that call. And then also making them nil by mouth. So you might think with aspirin, well, they're nil by mouth. There's other ways to give aspirin. You can give it PR. And through PEG and various things. But anyway, that's stroke, and it's pretty easy, isn't it? It's just scan them, shout for help. If it's not a bleed, aspirin. Cool. Sepsis. Sepsis 6. I feel like that has been grilled to death. But ultimately, confronted with a patient, they're not going to call you saying this patient's septic. Well, they might do, especially with the prompts these days. But they might be like, this patient is just a bit sick. They're a bit hypertensive, they're tacky, whatever. You review them. Just think in your head, is there anything that suggests they're infected? Are they coughing? Do they have a big angry red ulcer? Are they febrile? Have they got terribly painful urine? Are they confused? Is there anything that could be a sign of infection? Think it. Then you just go through sepsis 6. I'm not going to tell you what they are, because you know exactly what they are. Make sure you follow your trust guidelines for your antibiotic prescribing, and also make sure that you get the cultures ideally before you give the antibiotics. Ultimately, if you cannot get those cultures for whatever reason, the antibiotics are the things that fix this person, but the cultures are things that help us refine that treatment. Improve your diagnosis. That was because I was too lazy to type the different types of investigations you're going to need to do, but essentially you're going to want to do a chest x-ray to prove it is or isn't a chest sepsis. You're going to want to do a urine MC&S to prove it is or isn't urine. You might need to do a CT head and an LP, or someone else does the LP, but you might want to go looking around the CSF type region, etc. You want to do swabs, cultures, whatever. You need proof that this is an infection. The other thing is IV fluid. Sepsis 6 is like, just fill them with all the fluid, and that is really good. But if it's an old, frail person or a person with heart failure, be a bit more cautious with your fluid, and sort of like 250 mils of fluid stat, reassess them, make sure that that's not going straight onto their lungs because they're high, so we can't take it. And also be aware of when you need to refer to critical care. I'm not going to go for the hard and fast rules, because obviously it's sort of part of your comfort zone, but if this patient's showing that they're in an organ failure, so they're not peeing, the lactate's super high, they're not oxygenating well, they've got reduced GCS, like you need critical care help. Cool. Upper GI bleed is quite the dramatic one. I had a friend that used to call it like Halloween, because blood everywhere. Anyway, more likely you're going to see it's melena. It's not often massive hematemesis. It's more likely going to be melena, and you'll know it's melena because it's black lactate and it's the worst smell. There's not much to say, sort of like you expect it, you know, sorry, if you you suspect it, and then you should sort of play it like it is. So you need to get 2 large bore access sites. I mean, start with 1 and, you know, get someone else there that can get a second. You want 2 group and saves because it's likely that you're going to need to give them blood transfusion. You want to send off some bloods at that time, and you want to get a gas, you know, see is the lactate high, see are they starting to get unwell as a result of this. And then their blood, things that can help you is their hemoglobin really low, because even if it doesn't look like they've lost lots of blood, if their HB is low, they're going to need blood. And then high urea, that's just relevant for a diagnostic thing. If you've got bleed and your body is digesting blood, a byproduct of that is urea. So people with upper GI bleeds get really high urea, and their creatinine is fine just because it's the digested blood. You want med-reg help, because ultimately the definitive management is your upper GI bleed, and that upper GI bleed is your OGD. The OGD is done by the gastro consultant, sometimes gen surg, but mainly gastro consultant, and it's the med-reg that is the one that gets in touch with them. So just always let your med-reg know, even if you think you're like textbook managing it, let the med-reg know, because they're going to need a scope and you can't do that. High blood glucose. I'd imagine a lot of you might be quite grateful for this slide, because I remember really hating calls about blood glucose and just anything endocrine. So your first question is it a DKA? Because that's the thing that is the emergency. To do that, you just say, right, what is the blood sugar? The blood sugar is greater than 11, that's 1 point. Right, have you done ketones? Whether it's blood ketones or urine ketones, most of them will be blood ketones, because the BM machine also does ketones. So they say, oh, ketones grade 3, then you're thinking, crap, oh my God, this is probably going to be a DKA. Number 3, have you or can you do a VBG as soon as possible? And then you want to know if they're acidotic. If they have sugar of greater than 11, ketones greater than 3, and a pH of less than 7.3, they have diabetic ketoacidosis. First thing, or 2 things you're going to do, is go to that ward and you're going to get up the trust guidelines, because the principle of DKA management is fluid rehydration and insulin, but actually the finer aspects of that are a bit more fiddly. And if you follow the trust guideline, which will probably be like 11 pages long, you follow it, you will do it right. And it's a little bit of a faff, but actually if you just follow the trust guidelines, it will be okay, and it will feel a lot less mystifying. Just make sure, a couple of things, is you continue their normal long-acting insulin, they're on it, and make sure that you follow the blood monitoring requirements. So it's like a VBG, like half an hour, 2 hours, and using these regularly as well. So just make sure that you follow that, and the nurses will probably be able to do that for you, but just make sure that they know they need to do that. The other thing is, if they're type 2 diabetic, it could be HHS, which is sort of like a more annoying DKA because it's a lot less obvious. But essentially, if you've got a type 2 diabetic with high blood sugars, you need to calculate that osmolality, which isn't as hard as it sounds. If you have MD Calc app on your phone, or you just Google it, all you really need is their sodium and their potassium and their urea. And then you just bung them into an equation, and then you've got their osmolality. And if the osmolality is greater than a certain number, they've got HS and they need treatment. And it can be just as, in fact, it is just as bad as DKA. So always think that. And then also it could be a high BM, but with normal ketones and normal pH. And you may need to correct it. You know, if the BM is 11 with normal ketones and normal pH, you do not correct that. You know, they may need an insulin review. Then long-acting insulin might not be big enough, but you don't correct that there and then. But you know, if it's sort of 15 and above, you should think about it. If it's pre-dinner, it's worth giving a little bit of Novorapid, because they're going to eat, so you know that that extra insulin is going to be opposed. You're not going to make them go hypo, but if you're getting called at 9 p.m. or even earlier than that, but it's post dinner, so common and cool. And, you know, BM of 15, but they finished dinner and they're sort of looking like they're not going to eat again until the morning, I wouldn't give them insulin, because you're more likely to send them hypo overnight, and that's just a nightmare. And ultimately, hypos are much more dangerous than hyper, unless, you know, if it's not CKA. Hyper obviously is long-term damage to your micro and macrovascular system, but actually hypos are much worse. Cool. So also, I should say at this point, if anyone has any questions, feel free to just turn your mic on and turn your screen on and interrupt, because I realise I've just been talking at you, and I meant to say ask questions as you go along, but I didn't. But anyway, feel free to do that. We'll obviously have time for questions at the end.
Hi, Cleo. We had a question earlier about PEs. So would you commence Clexane before or after arranging a CTPA in a PE?
Almost always before, for a couple of reasons. Number one, CTPA, unless you're in A&E, is not going to happen quickly. Number two, for most people, Clexane isn't a dangerous thing to do. If they have renal impairment, if they're a high risk faller, or if they've already got a small bleed anywhere in their body, then it's more different. And then I would be making that decision in conjunction with my SHO or my MedReg. But if I was the F1, and I have been this F1 at 6 in the evening, and I've been called to see a patient, I think it's a PE, they're definitely not getting that CTPA until at least midnight, if not the day before. And I think it's safe to give Clexane. And bearing in mind, most patients in that hospital are on Clexane prophylactically, I would give therapeutic Clexane. Does that make sense? I mean, you probably are all muted, but I hope that makes sense. Any other questions at the moment? Cool.
There's nothing else in the
cool. Low blood glucose, as I alluded to earlier, is super dangerous. Your brain doesn't store any glucose, it relies on your blood glucose. If your brain ain't getting glucose, it ain't happy, and it's going to start dying quickly. So nurse calls you, doctor, patient got BM of 3. Your first question is, are they conscious? And if it's no, you just say, can you go to the hypo box right now? You get 50 ml of 20% glucose IV, and you whack it in. And if they don't have a cannula, there's other options. I can't remember off the top of my head, but there are other options. But you treat that right now, and then you get there quite quickly. Like, you know, walk briskly and consider calling 222, because that's bad if they're unconscious. If they're conscious, again, can you please go to the hypo box? Can you give them some glucogel or Lucasade? The patient, if they're diabetic, might actually have their own things that they prefer, and they've probably got some stuff on them. And then in that case, if they remain conscious, you just want to keep monitoring the BM, and once you hit about 5, then you're sort of fine. And then it's worth, if you've got the time, reviewing the insulin, because they might be on too high a dose, or make sure that you hand over will need an insulin review. Yeah, that's low BM. It's simpler to treat. Ultimately, the treatment is glucose and help, or glucose and chill if they're, that sounds dodgy, glucose and chill if they're conscious. Hyperkalemia can be quite overwhelming for some people, but I'll try to explain it so that it feels more simple. Ultimately, if you have too much potassium in your blood, it is going to mess with your heart conduction process, and you're going to change your polarization status, and you're at risk of arrhythmia, and that would progress into arrest. So been called, or you found the high potassium, the first thing you do is you get a 12-lead ECG and you see if there are changes. I won't go into the changes now. You should be aware of them. They're easy to revise and refresh yourself on, and they're quite easy to remember. So any ECG changes, you then want to treat that kind of there and then. So calcium gluconate, that doesn't lower the potassium, that just stabilizes the myocardium whilst you start the actual treatment. And the treatment is insulin, dextrose. The insulin drives your potassium into the cells, and then the dextrose means that you don't make that patient go hypo, because you're driving all of their sugar into their cells with it. You can also add in salbutamol. That also has a potassium intracellular driving effect as well. Not as strong as the other, but it's just a nice little adjunct, especially if, say, you're trying to get access and you're fiddling about, and you can just give them salbutamol, makes you feel better at least. And then also, I would say if they've got ECG changes, you should escalate anyway. And they'll need cardiac monitoring because that could easily progress. Or if you're just worried, escalate as well, actually. There will be you will have many mild hyperpotassiums in your career, you know, sort of like 5.6 or 5.8, and there's no ECG changes, and they're actually, you look down, they're using these and they always have slightly high potassium and they've got like a little bit of CKD. Those times, you don't worry, and I would suggest that you shouldn't treat because there aren't ECG changes, it's chronic. And actually, if you treat them, you're going to make them hypokalemic most likely. But anyway, in those situations, we're early doors discussing, and then actually kind of a month or two into F1, you get more FA with it. What's the other thing I was going to say? Yeah, they mainly cardiac monitoring, but they also might need dialysis. So that's why critical care will want to know about them if they've got ECG changes. Then reviewing the cause, look at their medications, you know, like potassium sparing diuretics and various other things, or if they've gone into renal failure, or if they've been poisoned, or something like that. And there's something else about I hadn't written on the slides about hyperkalemia. I'm sure it'll come to me anyway. Any questions on that? Hyperkalemia, because sometimes it can be a bit stressful for people. Ooh, cool. Sodium, I won't go into it because it's a very complex beast. Well, it's not that complex, but there is, you know, lots of things to think about. What I will say, if your sodium is too high or too low, it's really bad. You can get seizures, you can get cerebral edema, you can get osmotic demyelination. It's super bad. So medium changes in sodium, whatever, like you will need to think about them. They're not an on-call panic mode thing. But if they're less than 125 or greater than 152, you need to escalate. I'm not going to tell you how to treat these because it's quite a high risk procedure. Like stuff like hypertonic saline should be given by a very experienced person, preferably someone in critical care. Just know that if you see a super low, super high sodium, you need to tell someone senior to you about it. Basically, low peeing states, so either they're not peeing or they're not peeing much. For an adult, it should be more than 0.5 mils per kilo per hour. So, you know, if they're 70 kilos, you want them to be peeing 35 mils per hour. You know, if they're a little bit below that, you might not panic, but if they've got some low numbers, then you should really have a think about this patient. When I say review, I don't mean go and review them. It might be that you just ask some questions over the phone, but people not peeing or not peeing enough can be super sick. You know, it is organ failure ultimately if it's a problem with the kidney, and organ failure is something to be taken seriously because they're probably very sick. But it also could be a super easy fix. It could be like, oh, they're in retention, pop in a catheter, great, everyone's a winner. But that's something that needs to be fixed as well, because A, it's uncomfortable, or B, you're going to get issues with the kidney from wee going back up the ureters. So yeah, always think about it. Never just be like, oh, whatever, they're not peeing, who cares? It's something to think about. Fast AF, this is the only arrhythmia I'm going to talk about because it is, I think, a really common one that comes up again and again and again on call, especially because you've got old people and you've got sick people, and being old and sick predispose you to going into AF. First question is, are they unstable? You know, do they have a low blood pressure? Do they look sick? If they do, you need to escalate them because they need to be cardioverted either with chemicals or with electricity. You also then need to move on, be like, okay, fine, they're stable. See my ECG, it's definitely AF and it's fast. Most AF, you should just treat the underlying cause. They might have fevers, they're a little bit hypovolemic, they need some fluids, that AF will settle down. They might have, you know, whether heart issues like pericarditis, sinuses, they might have crazy high thyroid levels. These are all reversible causes. The key to AF is treating the root cause. But the thing is with AF, if they're bopping along at kind of 130, 140 beats per minute, and that goes on, eventually that heart is going to tire and get failure, and so, you know, start leaking fluid into the lungs, etc. So though in those situations you might want to slow it down a bit and essentially keep it simple. There are two options. One, their BP is okay, then you can give bisoprolol. And that's because bisoprolol naturally lowers your blood pressure a little bit. Or if their BP is kind of, and they've got heart failure, then digoxin. Look at the guidelines on how to start those. It's pretty straightforward, but you should look at them. And then the other thing is always think about anticoagulation. Because if you were in GP land or whatever, or you're doing your Jerry's exams, you'd always know that you would do your Chas-2-Vas, you do your has-bled. So always think, are they on anticoagulation? Because they're at high risk of having strokes. They've got AF. Cool. Arrhythmias, I said I wouldn't talk about them. I'm not talking about the arrhythmias. I just think you might get called about them. Just think, right, is it fast or is it slow? That's something I kind of want to know. And basically, everything that is not sinus brady or sinus tachy, you should discuss with the senior. Now, whether that's you WhatsApp your SHO or you call them and be like, oh, blah, 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 I think it's just first degree heart block or whatever. You should just chat with the senior. Most of the other ones are relatively serious and can produce an unstable, unwell patient. And then you definitely want help from your med reg. The other thing is, so the nurse has called you about this arrhythmia, you should definitely be going to the patient whilst potentially calling for your help, but also consider saying to that nurse, oh, well, actually, the patient's heart rate's 190 and, they're really old and they're lying flat. We should maybe put some defib pads on, one, to monitor the rate and rhythm, and number two, in case they deteriorate, you've got your intervention ready. You also want to think, is there an underlying cause to this arrhythmia? So is there potassium 7? Do I need to give calcium gluconate? Because obviously you know how to treat hyperkalemia now. The other thing is, if it's an SVT and you look at that, you get there and the heart rate's like 170 and you're like, yeah, that's definitely SVT. I saw that in med school, saw it in my finals, that's an SVT. You're not going to be giving them adenosine, but you might well be helping your SHO or your med reg do that. So you can start, get them attached to a monitor, start trying some vagal maneuvers, say to the med reg, do you want me to actually just prescribe this adenosine so the nurses can draw it up and get it ready, and then when you're here we can do it together? So that's something worth thinking about. But yeah, don't panic too much about arrhythmias. If they're big sick, you need help. If there's things that about like SVT and hyperkalemia, you can start treatment, but you always need help. High blood pressure, essentially you might get called about it a lot. Most part on call, you do not do anything about it unless it is they're getting symptoms from it, so nosebleeds, headaches, visual disturbances, or it's greater than 200, the systolic is greater than 200 or the diastolic is greater than 120. In that case, you need to treat them just like they're a generic and more patients, so oxygen, ATE, IV access, senior review. You're not going to be doing the management of that really high blood pressure, but you just need to know when to escalate. But yeah, if it's someone with 180, blood pressure 180, either they have hypertension or they're terrified and in pain because they're in hospital and their blood pressure is up to 180. So either way, you're not going to treat it there. Hypertension is a long, chronic disease that needs chronic treatment. You might want to document, you might want to hand over, but yeah, essentially you don't need to manage it acutely unless it's super high or symptomatic. Full on ward, last one, it's not a medical emergency, it's just something that you get called about loads, and we never got taught about it in med school. It's a common sense approach, but it's also the sort of thing that the nurse will be like, doctor, you need to do a falls review, and you're like, I don't know what that is. Number one, common sense, approach the patient, is it safe? If they're like, a pool of water because you're in there's that hospital that flooded today, I think it was Lewisham or somewhere, you're in a flooded hospital or whatever. Number two, approach it like you would in a full person. Number three, there is a full performer in every hospital. The nurse will probably have it printed and ready for you. You just need to follow that. The crux of it is you want to make sure that they don't have a head injury. And the first thing to ask yourself is, other than the ATE stuff, you want to say, are they anticoagulated? Because if it's an unwitnessed fall and they're anticoagulated, pretty much every falls performer says they need a CT head. They might not be anticoagulated, but you might be worried anyway. There might be neurology, it might be a particularly, it might be a loss of consciousness. You also want to look for other signs of trauma. So long bones, fractured neck of femur, abdominal pathology, etc. Escalate it if you're worried, if you're not quite sure, call your SHO, call your med reg, whatever. And then also you want to think about why they're falling. You know, if they've just tripped over because someone has left a wire from the OBS machine out, then you just move that wire out of the way and just be like, why did you leave that there? But it might also be a medical cause. So do a lying standing BP because they might have had a big postural drop. Think about cardiac causes. You know, do they need to go on cardiac monitoring? Do you think that they've had some arrhythmia and they've just gone bam because they're in third-degree heart block? Think about neuro causes or environmental, but we've already spoken about that. Cool, so I've rattled through that. You guys must be exhausted. That was a lot of info. Any questions? Don't be shy, or do be shy. Ask on the chat or verbally if you want.
Thanks, Cleo. There's quite a few questions in the chat. I'll read them out for the sake of the recording. So the first one is, how dangerous is calcium gluconate? Can I prescribe it to be safe if the ECG isn't that convincing and the patient's bloods haven't come back?
No, don't panic about it. I mean, you might make them hypercalcemic, but that's not the end of the world. Don't worry about it. I mean, like, what I would say is if their potassium is 5.8 or 6, don't be jumping to that calcium gluconate before you get your ECG. If their potassium is between 7 and 8 or even higher, jump to that calcium gluconate. So, you know, is it a big hyperkalemia or borderline hyperkalemia? That is what I would say.
Thank you. The next one is from Ahmed, and he's asking for the role of furosemide on oligoanuric patients.
Oh, well, now you've probably done ITU recently, so they love it there. You know, patients not peeing, give them furosemide. Ultimately, you've got to think of the cause of why isn't this patient peeing? Like, you know, it's a bit lolled, isn't it? You can give them furosemide and then they pee, but actually, have you fixed the cause? So you want to know, is this patient hypovolemic? Why are they hypovolemic? Are they ragingly septic? Is this patient in renal failure? Etc. etc. I can't quote for you the papers. I have intensive care friends that could. I'm unfortunately not that clever, but what I would say is don't go thinking about furosemide treating anuria. Think about what is the cause of it, and that's the only way you should be thinking as an F1, as an F2, even at my level. I just think, why are they oligo or anuric? Leave the furosemide to the critical care physicians. Does that make sense?
Cool. So a question on stroke. So if you suspect a stroke in the community or on the ward prior to a CT, should you give aspirin before you're sure it's an ischemic event?
I knew this was coming. So if you're out in community, so I did this with my neighbour the other day. They didn't have a stroke, thankfully. I gave aspirin because ultimately the antiplatelet isn't going to harm them, but actually it might be quite a long time until they can get to a CT scanner. But if I'm the F1 on call and I go to a ward, that CT head is going to happen really quickly, especially if you put out a thrombolysis call, which you should do. So don't worry giving aspirin because you'll have that answer super quick, so you can get things perfect. But if you're out in like rural Northamptonshire, like I am right now, you may as well give them aspirin. But yeah, from your point of view, CT head thrombolysis call, you'll have the answer quickly.
The next question is, if a person has cardiac arrest and you put out a crash call, what can we do until the team arrives apart from chest compressions and keeping their airways open?
So you've hit the nail on your head with airway, chest compression, keeping airway open. So that's your gold. Really, I would say chest compressions actually, because ultimately your heart ain't pumping the blood to the brain, the oxygen ain't gonna do much. So your chest compressions, so it's like BLS standard chain of survival, the stuff that is all over social media, primary school kids. So chest compressions, and then your next thing is early electricity. So you might be the one doing compressions. If you are, you shout to whoever is nearest, doesn't matter who they are, unless they're a child or a crying relative. You say, can you please get the crash trolley? And then you say, please, can you attach the paddle to this patient? And you can make sure you keep doing those chest compressions. You must keep perfusing the brain. They can attach the paddles around you quite easily because it's just, well, I can't see most of me, but you know where the paddles go, one here, one on the side of your chest. So you keep compressions, you switch if you need to, then someone gets those thingamajiggies on. Then when it's rhythm check time, now if your defib is in automatic, it will tell you do a rhythm check, and that's when you stop compressions and you look at the monitor. And then if it's on automatic, and at your stage it should be automatic, it will say shock advised, or it will say continue compressions. Once you've done your advanced life support, which you will either do in F1 or F2, you can put it into manual, you can analyze the rhythm yourself. I wouldn't worry about that. So keeping it simple, chest compressions, then put the pads on. If at this point you've got friends arriving, because there's other F1s and F2s on the ward, someone can then go on the airway and put oxygen on. Oxygen first, then get an airway adjunct. And then if there's more people, I would say get access if there's not access already, and get a gas, because that gas is golden, because from that gas, you've got a few reversible causes. So you have got potassium and sodium, you've got oxygenation, and acidotic and lactate sort of relevant. It's going to be crap anyway. So gas, so we're going for compressions, we're going for defib, we're going for oxygen, airway, then we're going gas. And then if there's someone calm there, I would have someone opening the notes and working out, who is this patient, why are they in hospital, is there any clues as to why they might have arrested. At this point, if you've done all of this, you have smashed it. You have won the game of cardiac arrest. You've done a really good job, and hopefully you'll have people there. Cool.
Thank you. One more question, I think, at the moment. So it is, do you have any tips or resources to improve confidence with ECGs? And someone else has responded suggesting the ECG Made Easy by John R. Hampton. But
yeah, great. So I'm glad you said that. ECG Made Easy, and also for slightly more advanced ones, Life in the Fast Lane. That's also a website. But I think for me, it's all process driven. So knowing my process, and I think you might have picked that up in the talk that I'm all about having a structure and a process. And if you got that, you're gold. So with ECGs, practice looking at normal ones and making sure that every time you look, name, date, what is the rhythm, what is the rate, what is the access, what are, is there anything obvious? Is there any ST elevation? And, following it in that vein that you've been taught in med school, having that nailed down, because if you do that, you won't miss anything. And you might find something and not know what it is, but you won't have missed it. And that's the important thing, is you might not know, is that a left bundle branch block? Is that ST elevation? Is that an S1, Q3, T3? You might not know that, but you definitely, because you've been thorough and systematic, you definitely won't have missed it. And you can always say, SHO, friend, reg, whatever, what do you think that is? But you won't have missed it if you stick to the process.
Thank you for that. I just wanted to add on also, with the ECG Made Easy, there's also a companion book, I think, called like 150 ECG problems or something. And 75 of them are quite easy, and then 75 of them are like next level. And I found it really, really useful to work through that. Like you said, they kind of explain everything just as you would present it. So it was quite helpful.
Cracking. Good question.
I'm just getting a lot of thanks through in the chat now.
Cool. So I've got last two slides that I just literally, you could probably just look them up later. The useful apps I talked about earlier, you probably know most of them. The one here, induction app, definitely get that. It's just basically got all of the bleeps and extension numbers in your hospital. So if you want to know the micro regs bleep, if you want to know the gastro consultants, whatever, it's all on there. Download it and you can customize it to your hospital. Micro guide is the antibiotic guidelines. You download the guide for your hospital. So once you get in there, get it to your hospital, and that is the local antibiotic guidelines. MD Calc is great for sorting out your calculations. So whether it's Wells score for PE, Cockcroft Galt score, all of that random stuff that you think, I'll never know that, get MD Calc. BNF, pretty self-explanatory. Careflow, most of you won't have this. I'm just using it as an example. Your trust may well have its own app. So my trust in Bristol has Careflow. It's amazing, but it's basically got all of the patient data on it. It's awesome. And then Pocket Doctor. I don't know if you can still download this. I used it in F1 and F2. I thought it was gold. It just had simple plans for everything, commonly prescribed drugs, etc., etc. It was great. And then last slide, I won't talk through these. I just found these links and I just thought they were helpful. So the first one is Oxy Stop. It's just like all your common bleeps, and it's nice thorough table. And then this one is from some random hospital. I think it's Brighton, maybe, no, or Bournemouth. And it's just like their F1 survival guide. It's just really thorough. I really liked it. Like some of it was like Bournemouth specific, but a lot of it was just helpful F1 stuff. And then the last one is just this random PowerPoint I found that is probably like a better version of this talk. So sorry if you listen to this, haven't liked it, and then you have to listen to that one. But anyway, so those are my links. Anyway, thank you. Any more questions?
There have been no more questions in the chat, but I just want to take this moment to say thank you, Clea. That was actually an amazing talk and really, really informative. So I'm sure everyone appreciates you giving up your precious time as well. Yeah, there are a lot of questions in the chat as well.
Great, lovely. Well, lovely to not meet you all. But anyway, I wish you the best of luck. You will be fantastic. And just keep it simple, stick to your structures. You'll be great.
Great. Thanks, guys.
Bye.
I'll turn off the recording.